Thanks very much for inviting me to get to meet you and to learn more about your work, and giving me the opportunity to share a little bit about some of the work that I'm doing in New Mexico. Just to follow up on what Bill was talking about, the RWJ Center for Health Policy is an unusual beast. It's really an entity that sort of has brought together a number of the disparate themes in my career under a single roof. RWJ was kind enough to give us an endowment and also an operating grant to create a center whose main mission is to increase the diversity in the social science disciplines, primarily sociology, political science, and economics. Increase diversity of those disciplines with people who can be prepared to be the next generation of leaders in health and health policy debates at all levels of government, whether you're talking about local communities or whether you're talking about tribal communities in the American Indian community, because the special focus of the center is training Latino and American Indian students, but also other underrepresented minority group members. So of the 26 doctoral students we support, the majority are Latino. We have 3 African Americans, 2 Asians, and 5 American Indians. A community that often is forgotten about even in Indian country. We have 6 postdoctoral fellows, 4 of whom are American Indian, and 2 Latinos, and 6 assistant professors that we've now brought on, 5 of whom are Latino and 1 American Indian. So over 3 years of trying to implement this effort, we've really tried to create a set of activities that are built around research and research training, because we're really looking at training people in the social sciences who are getting PhDs. And a PhD is a research degree. So we focus largely on that effort. But it's research that's focused on action. So it's really a policy analysis, policy-connected research. We also do leadership development work because, as I said, we're trying to train the next generation of leaders both in academia but also in the community. And as a result of that community interaction, we do community capacity building. So part of what I'm going to talk about today is just to give you a little idea of how this is put together, how it shapes the research that we're doing, and an example of a population laboratory. I only use those terms in academic environments, that we're doing along the southern border, along the New Mexico border, in a very rural community in the southwestern part of the state. The state's kind of a square, so it's kind of at this edge of the state, near Arizona and New Mexico, or Arizona and Mexico. And it's a partnership with primarily a single sole provider there, a community health center that is located in that region. And luckily we have community health center leaders who still are part of the community health center movement of the 60s, rather than community health center leaders who came out of the Reagan era, where they were turned into primary care clinics. But the people who started community health centers, as many of you probably know your history, came out of OEO, the Economic Opportunity Office in the Department of Health, Education, and Welfare. And so many of them understand that in order to produce health, it's not about providing only primary medical care. It's about creating opportunities for people and communities to thrive economically and socially and educationally. And so we've tried to work with community health centers along the border to begin to revive that concept of what a community health center is about, and in particularly in these communities that have lost a sense of identity, a sense of purpose, and a sense of hope. So that's kind of what we're up to. And those are the 3 elements of the center: research training, leadership development, and community capacity building. I was talking to your dean a few minutes ago, and she said, you know, we really don't connect up healthcare reform with social work and the work that we're doing in training social workers. And I said, well, it just so happens my first slide today is about healthcare reform a little bit because it reflects some of the philosophy that at least I bring to the work that I do. And the first thing to recognize is that it doesn't matter what we're talking about nationally. All healthcare is local. It's only going to play out in the local circumstances and resources that are available. And how a community organizes their own care will dictate whether or not that community is producing health or whether they're simply trying to treat symptoms of illness, which is the medical model. You treat illness. You focus on learning about disease. You don't learn about, having been on the medical school faculty most of my career, you don't learn about how you produce health. So, you know, healthcare and healthcare reform is really local. And Bill and I were talking yesterday or a couple of weeks ago about the fact that community development funds out of healthcare reform are going to be coming out soon. And what are those funds about? Those funds are really about investing in community health. Something I know that all of you are interested in and engaged in as I look at the work of the faculty here at the School Solution. But the rhetoric of healthcare reform is quite different. The rhetoric of healthcare reform is really about how do we create insurance coverage so that people can get more medical care. Last time I looked, more medical care never produces better health or more health for a community. It certainly increases costs, but not much else. So, you know, most of the rhetoric revolves around insurance. It revolves around medical care as a commodity and as an accepted commodity to be bought and sold in the United States. It's talked about as a business. The business of healthcare was everywhere in the debate, everywhere in the discussion. And little did you ever talk about health. Little did you ever hear about how communities would organize and develop. But within healthcare reform, the Affordable Care Act, there are pockets of hope for all of us because there are these investment acts. There is something I'll talk about in a little bit. It was based off a little project that we were doing in New Mexico over the last 3 years. We call them HEROES, but in the Affordable Care Act, they're primary care extension projects. Then each state's supposed to get about $10 million to try these things. I don't know if we're going to make it to that point when those dollars are going to come, but we continue with our HEROES, and this is an example of a HEROE that I'll be telling you about. And it's really about healthcare being thought of as part of the competitive market for goods and services in the United States. That's the rhetoric at the national level. At the local level, it's very different. At the local level, as you well know, it's about people wanting to alleviate pain and suffering. It's about people recognizing that they need to prevent themselves from getting ill because they can't afford to buy into the system. So healthcare reform plays all these sort of weird things in this cauldron of what we call local communities. And that's sort of the focus of where our work is. One of the things we also know, and that the Healthcare Reform Act only gets or begins to address in bits and pieces, is the issue that the vast majority of communities actually have pretty poor medical care. And if you look at low-income communities, the quality of that medical care is even poorer. Much of the work I was doing here for the California Endowment over the last decade was working in low-income communities and looking at practices that were located in those communities. And what you saw in those practices was that most of the practices were small, independent, disconnected practices, often with people who came to the area without an understanding of the local region or the local community, who would open up their shop, but they were onesies and twosies. They often didn't have medical hospital privileges. So a little hospital project that we did with some of my doctoral students in East LA looking at people who came to the emergency room. We were asking the question, everybody said, well, people were coming to the emergency room because they didn't have primary care. The fact of the matter is that the people who showed up at the emergency rooms, 60% of them had a primary care doc they could identify, and that they'd been seeing. Why were they in the emergency room? They were in the emergency room because these practices couldn't handle their problems. Their medical issues blew up. They didn't have referrals to specialists. They didn't have hospital privileges. And, you know, where else in the world can you have a physician not be able to refer to a hospital? It's just crazy, nuts. But, I mean, that's what we're seeing. And so, you know, quality in the communities that we're working in are very poor. And these kinds of fragmentation and other issues are not well addressed in the Affordable Care Act. However, some of the modernization issues are. So the simple things like just getting medical records, getting other things that work are part of the Accountability Act. And so we have to take advantage of some of those. And in fact, this little project is an effort to some degree, rewire the community health center that's located in that area. Community health centers actually do quite well under the Affordable Care Act. They not only get expansion money, but they also get investment money for infrastructure, which is very, very unusual over the last 2 decades. But the other thing is that for many of us, healthcare is really about civil rights and human rights. And we even have Title VI, which exists but often hasn't been enforced. And that is the right to language appropriate services. So we're trying to deal with some of these issues, both in the course of this example, but also in the course of healthcare reform's implementation. Because there's a recognition that much of the medical care and the fragmentation needs to be dealt with. But it's not going to be dealt with in a systematic way. It's going to be dealt with in the way that social workers are accustomed to dealing with it. And that is, the approach that we've taken is, on the medical care side, you'll see it called a lot of different things. But it's fundamentally about casework. It's fundamentally about how do you get the medical care system to understand the importance and the value of casework. And in most of the literature in the health sciences, there's been this adoption of, over the last 10, 15 years, people recognizing, oh, promotores. Well, what do? They mostly do casework. Community health workers in the American Indian community, what do? They do casework. Except that what they're doing is bringing resources not from the human services side of the community, but from the medical services side of the community. But it's fundamentally about the same idea, that people need help getting through a fragmented social structure and system that we've created in our society. That's largely built on the notion that everything is a commodity. So if everything is a commodity, then you've got to shop around in order to put your basket together to make everything work. And sometimes you need people, whether it's Nordstrom's, who also have caseworkers, who can help you go find that special gift for your loved one when you need it, right? That's, you know, it's the basic same kind of idea. We've got lots of things out there, we've got lots of stuff in the inventory, but it's all separated, it's all fragmented. And so what I'm going to talk to you a little bit about is how we, in fact, are trying to bring the notion of casework into the medical context, but not simply to the clinic itself, but recognizing that the clinic operates within the larger structure of the community. And in the healthcare lingo, that's really described as primary prevention. But primary prevention and a community orientation really has a number of dimensions to it. And I try to list out some of them here for you, and you'll probably recognize an area that you teach in, or an area that your curriculum tries to address. For me, lots of people said, oh, you do policy stuff. You're down here at this bottom area. I said, yeah, I kind of do some of that stuff, but we're also interested in strengthening people's individual knowledges and skills about how to take care of themselves. So some of what I've done in the past was I currently am and have been the Chief Health Advisor for Univision Communications Corporation. And we put together the first Peabody Award-winning health promotion and disease prevention program for Spanish speakers in the country. It was a media campaign that went on for many years that took advantage of the 5 platforms of Univision. It included radio, television, cable television, a web portal, and 3 record labels. And so imagine pulling the talent from all those different areas, identifying particular individuals who had an interest in a particular disease area or entity, and using them to convey the information about how to prevent the illness from either getting worse or preventing it altogether. This is a very powerful tool, and it still has been used in local communities by the radio stations and the local TV stations. There's an active group here in Los Angeles that continues with identity projects. But primary prevention requires all these dimensions. It requires action in all of these areas. If you only do one, if you're only engaged in one, the community actually is not going to be well served. So we're trying to do a little bit of all of this in our work at the center and in the research that we engage in. We don't just do research to develop the individual knowledge that we're interested in at the top for individuals. We're also interested in the knowledge of how it plays out and it's translated into changing effective legislation and policy to change the environment. This is a little graph that some partners that I work with, the Prevention Institute, some of you may know them in the Bay Area, and I worked up, because it kind of captures the framework of the work that we're trying to do. Much of it gets framed as health disparities, that is the difference, racial and ethnic differences in health outcomes that we've observed in our society for several decades, actually several centuries. And when I came to many places, and I say, "Oh, I work at the Center for Health Policy," people immediately think, "Oh, then you work on medical care." And I said, "Yeah, we work on medical care related stuff. I do a lot of quality improvement work over the years. We look at how to modernize the medical practices I was telling you about, increasing the knowledge of physicians who are providing medical care. But more medical care doesn't build more health in a community. So you got to take a step back there and really look at the individual conditions and behaviors that bring people to need medical care. And if you actually want to look back a little further, you're really looking at the environments and the opportunity sets for people that either promote their health or denigrate it. And if you really look down at the root causes, it's really a social issue. And that's kind of the role that social scientists have something to say in this chain of events, which is why at the Center for Health Policy we're focused on training people in social sciences who are interested in looking at phenomena like poverty. We're interested in looking at phenomena about individual relationships between power structures in the political science world. We're interested in those kinds of issues. So this forms a little framework for how we get social scientists who are interested in these root cause questions and help them connect it up with these outcomes that produce health in communities. And it goes through a chain of events, so you don't do one, you can do the other, you can do whatever. But this is a way of just sort of thinking about the trajectory of health disparities that helps me connect the dots for people in the social science when they tell me, well, I don't really do health. I study poverty. And as crazy as that sounds, that was one of the first conversations I had when I went to the University of New Mexico campus and went to the sociology departments. And I'm sure you must face that here as well. Well, by way of background, we often think of, well, let's look at causes of death. And most people think of these 5 as the major causes of death in any community: heart disease, cancer, stroke, diabetes, injuries, violence. But these aren't really the causes of death. If we actually look at the literature and understand what what underlies these medical causes of death. We know, understanding that it's really about diet, it's about activity, it's about tobacco use, it's about alcohol and drug use. These are the real causes of death, and these are really about social opportunity sets and behaviors. So what we try to do is really focus on community health by looking at sort of these three dimensions or areas of opportunity for action. One is really about equitable opportunity, and looking at how the distribution of opportunities and resources in communities are laid out. The other is about place. I know most of you understand the importance of place and its role in creating a sense of safety, how look and opportunities are really played out in communities. And finally, it's about relationships. It's about people and the relationships they have with one another. And that's fundamentally what it comes down to. And sometimes we just don't focus on that part of it enough. We're too focused on the place issues and whether the painting works, but we don't worry about whether or not the people in that community can work together. We've kind of looked at it in this way, at least from the academic point of view. What in these three areas, what does the literature say, where are there opportunities for social scientists to grab a handle on some of these contributors to increasing health in a community? And clearly, when you look at equitable opportunity, we're looking at issues of jobs and ownership. We're looking at the quality of education that's available. Right now in Tucson, the Tucson School District, how many of you are aware that Chicano studies and ethnic studies in the Tucson School District have been outlawed by the state of Arizona? There's a real war going on that largely goes unreported because the Today Show is more interested in talking about what the bridal dress of some princess or to-be is going to look like, instead of focusing on what's happening in our country. And this story is actually quite amazing. This curriculum, Chicano Studies curriculum, is the target of attack by the state of Arizona. It is probably a casebook study for some of you in this room. This is a program that in our society we say, oh, it was designed for losers. These were kids who were dropping out of school, who had no interest in continuing their education, who in 6 years has graduated 98% of the students that were brought to it. This is a program that has inverted the disparities in education outcomes that the state of Arizona tests for in reading, writing, and math. And the Chicano Studies curriculum doesn't teach math. It's about history and literature. So educationally, what's going on? What's happening? Why does the state want to destroy this program and stop it from further up? You know what they say? In the bill itself, the law itself. It's seditious, and it's a threat to national security. Why? Because they're educating little chicanitos. These are kids who are now going on to university and higher education rather than jail, where the rest of their cohort end up, or 60% of their cohorts end up. So, I'm sorry, I got off this, but right now we're in the middle of a huge potential lawsuit that we're likely to win in Tucson, but lose the battle of the educational battle, because that program will be gone. They just won't be able to survive the length of time it'll take to get through the course cases. Anyway, it's about people, and people. It's really about how you create social networks that work in a community and the kind of trust you build among the institutions in those communities. And so these are the areas that at least I'm trying to sell to our faculty at the university are areas where their research can contribute something to, but also serve as a guidepost for action in local communities. Skip that. This is just something. When I went to New Mexico, I've been living in the East, as you know, for a while, and I was asking friends, where could I go get something to eat? And they said, well, you can go down to this place. And I said, well, what's good about it? He says, the plates are this big. I said, oh, well, that's great. But you know what? You can get refills as many times as you want. They were excited. They had little big giant plates covered like that. And I came across this sign, which of course kind of captures it all. Burritos as big as your head. So I took my daughter actually to the Indian Public Cultural Center for lunch one day. A marvelous place to visit if you come to Albuquerque. And she said, she wanted a burrito. She thought, okay, I should get a normal burrito. They bring out this plate. It's as big as my arm. It's enough for 2 families to eat for a week. And the only reason I raise this is that this is the kind of advertising in place that goes on, the kinds of norms that we've been setting in our society, that we look at it, we laugh, but we don't realize that we're actually creating an acceptance of it for our children and others. Let me tell you explicitly about this little project that we're doing in Hidalgo County that I mentioned earlier. It's in partnership with the Hidalgo Medical Services, which is a community health center located in this rural part of New Mexico. It's also in partnership with the Prevention Institute, as I said, who've been my partners for a while in doing this kind of prevention work and this community resilience work. And it's a project that is to some degree designed and identified by the community. We went to Hidalgo and worked with what we call the CAC, the Community Action Committee. I think a number of you have worked in other places and probably have national or local advisory committees or whatever. Well, I like to always emphasize that we're there to change something, to make something happen. So we worked with CAC, and the CAC decided, to my surprise, I thought they were going to pick diabetes or obesity or alcohol or something. To my surprise, they wanted to deal with hypertension. Now, who would have thought hypertension, right? Okay, so yeah, hypertension is probably rampant in the community, but I had no idea that the community itself thought of high blood pressure as something that really needed to be addressed. That was severe and critical, and it certainly is. But it never would have crossed my mind. And unfortunately, a lot of my colleagues seem to always have the right answer. They know what the community needs. So I'm not telling you guys anything, because you guys are very community-oriented, but the community wanted to deal with hypertension. So they were going to be bought into this already. This project was funded by an NIH Center of Excellence grant, really to do these 2 things. One was to begin to address the Institute of Medicine's issues around how one conducts cost-effectiveness research in community settings. That was from a researcher's perspective. That's what we were interested in trying to address. It was also what NIH was interested in doing, because they were getting big money out of the Affordability Care Act to do CER, but nobody knew what CER was, right? I mean, how many of you have heard of CER before the current funding rules? Unless you're involved in pharmacy or in the old concept of cost-effectiveness research or analysis, which has nothing to do with the current incarnation. Well, it has a little bit to do with the current incarnation, but it's not the same thing. Most people hadn't really thought about this. And most of this work had been looking at the effectiveness of clinical interventions at the micro level. And in order to find the best practices that would be funded and that would be part of insurance benefit packages. That was the underlying rationale for a lot of this in Washington. But, you know, those of us who believe that you can't just change the best practice in the clinic between the patient and the doctor without dealing with the larger set of things set out to try to understand how do we improve the best practices for hypertension while at the same time creating a community environment that supported that kind of clinical intervention. So we've engaged the community in developing and implementing and translating what we call La Vida Promotora intervention. It's really, as I said to you earlier, it's really about a case management intervention that ties together both the clinical aspects of hypertension care with community education and community resources for making that treatment regimen possible for people in rural communities. The second thing was really looking at how do we assess the effectiveness of this kind of intervention, including this other concept that we have, which we call heroes. Heroes are an idea that comes from the agricultural community. How many of you have either known or worked with agricultural extension agents? There are a few of you. Agricultural extension agents were put out into every county in the United States by the Department of Agriculture to help farmers, industry, help farmers be successful, to find the loans they need, to find the seed they need, to find whatever it is that they needed in order to be successful. We took that same idea and introduced it into healthcare in New Mexico about 3 years ago when I arrived to do the following. The state legislature had said the university's health science center has got to serve every citizen in the state of New Mexico. There's no way we're going to move the building from Albuquerque to every place. How are we going to do this? We can't get all the people to come to Albuquerque. The distances are huge. So how do we get the university out to people? The idea of using extension agents occurred to us. And so now we've started populating counties and regions with extension agents whose sole job is to find out what communities need, resources, medical resource-wise, and bring it from the university in Albuquerque to that community. So that's one of the sort of little funny interventions that we're trying in this arrangement. We've got 6 heroes across the state. We're currently using a regional approach. But the hero down along the valley, along the border, is working in this Hidalgo project. So when we need specialty care, because the primary care clinic, remember the community health center, Hidalgo Medical Services, only has primary care. So when we need specialty care, we need other kinds of interventions, the hero is responsible for going out there and recruiting. If you've ever been in the Army, you have the corporal who goes out for the sergeant and somehow or another reappears with the supplies that you need when you're out. That's kind of the hero idea. Well, this project is really trying to address this issue of how do we in fact do comparative effectiveness work when you're talking about community interventions. And so this is a population laboratory we've set up to try to understand when you do a community intervention that is a combination of both clinical and community public health or education, how can we evaluate the effectiveness of that so that that can then be translated to the next community health center along the border who serves a similar type of population. So we now have a series of community health centers who are lined up to from San Isidro in California all the way down to the valley in South Texas, who will then be the next places that this effort around hypertension be translated to. So that's kind of what we're up to. I'm glad to take questions and learn more about what you're doing, or tell me that I'm completely nuts about what I'm trying to do. So I'll leave you the floor now.
Yeah, I'm just interested in how you resolve the continuing uncertainty and the contradiction it raises between what you want to do and what many of us in this room want to do in a tumultuous, unstable political environment in terms of policy and program development and implementation. Do you, I mean, how do you harness those pieces together? You work with what you've got and reach for whatever you can and bring it in ad hoc? Or, I mean, how do you think about it? Because you want to have stable implementation. It takes a long time to make these changes. You need to hold them in place.
Well, that's why I started with the first comment. And that's, my first comment is that health care is local. So every local community is going to have different kinds of resources available to them. They operate within different county, state, regional, and federal constraints, as well as resources. And so that the issue is that you can't just say, this is going to work. If this project works in Hidalgo County, New Mexico, I'm dealing with the county setup. Counties are really the units of operation for healthcare at a local level. They've never been really analyzed in health and health policy. When we talk about health and health policy, most people focus on the state as sort of the minimal unit of analysis. But the minimal unit of analysis is really the county. Local jurisdictions have a lot of play and a lot of leeway in how things get implemented. And it's where the dollars from different streams actually end up. In my federal career, I tried many, many times, and you can talk about this, trying to bring streams of dollars that seem to make sense so that the fragmentation goes away at the top. It's virtually impossible. Education gets their stream of money, agriculture gets its stream of money, and agriculture is important because it's where food stamps is located, it's where commodities that get sent to the schools is located. I mean, they play a big role in nutrition and in our society. And the healthcare people get their money on a different stream. The trust funds, Medicare has its own separate set of money. So if you actually wanted to do this at the national level from a policy perspective, you'd be fighting committees after committees after committees in Congress, all who want jurisdiction over those dollars. It's impossible. So where can you actually blend dollars? You can only do it at the local level where the dollars finally trickle through. And so dollars are important. It's what greases the wheels. But it's not enough, because then you have all the other sort of local regulatory constraints or institutional constraints. And they're different from community to community. Just look at LA County versus Orange County. They're right next to each other in the same state. Completely different operating.
Yeah, and I think this leads right into my question, this whole issue of coordination. And you have the HEROES program that you have put out in different places. And I'm sure that everybody sat around the table and agreed that they were going to provide the resources that were needed, that were identified at the local community. But when push comes to shove, people will say one thing when they're signing agreements, but when it actually comes to actually providing the resources, there's always some excuses, oh, we can't do it this time.
Not today.
Yeah, or we don't have the monies. And how do you deal with that kind of situation? Is there some kind of a backup fund or that will provide those kind of resources? Otherwise, we're just building expectations at the local level and without any resolution.
Well, in this particular case, this is an example of what I'm trying to do from a university setting. And that is, I'm trying to concentrate research and research resources in particular communities or locations. In this particular case, we're focused on the rural county of Hidalgo. And there are a group of researchers from universities and from other universities who are now investing in this one community so that you have infrastructure that will last for a longer period of time. I'm doing something similar in urban Albuquerque, where the center has seed grants for faculty members, and our call went out to faculty members who thought, well, I'll just follow my research project. But the research projects, the call centers research projects to be in a particular location. And these are 3 low-income community areas, neighborhoods in Albuquerque that we're focusing on. And then we have the next stage is a population lab in northern New Mexico, which has a different set of historical roots relationships to the state, power structure, a whole variety of other things. And it's my hope that at least in understanding those three kinds of local implementation arrangements, that we get a better sense of how you can translate these kinds of local implementations to a broader set of communities.
I was wondering, kind of following up with this kind of last idea of translating this implementation, how could the comparative work somehow can be studied when you're basically from your model from the very beginning understand this community is very different in terms of resources, investment. How do we think about actually spreading a model that may work when we're really realizing the uniqueness of the different settings? One, and a kind of a follow-up question is, there was this extension workers that kind of work between the community and, in this case, the university. But it seems like there's other extensions necessary to kind of go, for instance, with the county, that somehow keep some level of congruency, right, in terms of either formal or very informal ways of implementing practices. So I wonder your thoughts about this kind of too.
Well, take your first question first, which is how do we think about evaluating these translational efforts of implementation when every community is different? Well, you do it by really taking at least for those of us in academia who are interested in looking at this, you have to take a more abstract view. And that's why I showed the three areas that we concentrate on, which is place, people, and equal opportunity. And within that, there are the pieces that differ from community to community. But from conceptual level, those are kind of the three larger concepts that you're working with in any community and any implementation. What the little details are going to be like are going to be different. But at least from the perspective of trying to understand how you put the pieces together in any community, you have the sort of larger building blocks that you're working with. Sure, you need an extension to the local officers. In rural communities, you don't have that many people. So, you know, if you're treating somebody in one project, that's very likely to be the DIA or DO of the county officer or the judge or the sheriff or wherever it is. So there's not many sort of degrees of freedom in rural communities. So you can maintain those kinds of relationships fairly easily. In urban communities like LA, it's much harder. It's much harder to work that kind of relationship issue and keep the county supervisors aware of what's going on in Compton, for example, or in Bel Air, or wherever you want to talk about. But yeah, you still need to do that, and that's why Dr. Vega's so good at it.
In LA County, the big sources of money over the last many decades have been Medicaid for low-income people. So the county, and Medicaid did not reimburse clinical care, primary care, virtually at all. It mostly hospitalized hospital care. The county actually had an incentive to stick everyone in the hospital and just get the revenue from that. Except they had any money left over in Medicaid, they'd use it for uninsured people. So Medicaid did two things. It put people in hospitals and treated their surgeries. And it did the uninsured folks. It took care of enough of them that LA County could keep that going. So I'm just wondering, in the Affordable Care Act, I know there's more money for clinics. I've read that. A lot of new money, actually, for clinics. And a lot of good stuff like that. You mentioned infrastructure for these clinics. But did it fundamentally... But Medicare is going to go even bigger by 2014. It's going to pick up a lot of these uninsured folks. And has the basic focus of the big money programs, not the public health programs, which candidly are a drop in the bucket compared to the sheer size of Medicaid money. Has Medicaid been fundamentally changed by the Obama legislation, or is it more of the same?
No, actually the payment structure hasn't been changed at all. And that's been part of the argument, is that the healthcare reform debate didn't focus on one of the major deficiencies in our system, and that is the payment structure, payment incentives.
Right.
And payment incentives probably won't be addressed anytime soon, unfortunately, because they are misaligned with sort of the notion of producing health. They really are about putting people into procedure-heavy, hospital-intensive work.
And there's really no cost control in it at all.
No, not much. There's a little bit of tinkering and experimentation, but not much on the cost side. But what is to say is that USC's medical center, USC's medical school, and just like University of New Mexico's, have done great guns. I mean, they've been making money hand over fist off of Medicaid.
Right.
And that's until we're willing to accept that as an institution, that we have to change that and have them on board as part of the political voice saying this is the wrong thing to do. It's going to be hard to do.
As long as we can get an earmark for USC.
Yeah, thank you. I appreciate it. This isn't my area, but I'm just struck at how many connections there are with the fragmentation in education as well too. The local versus the national versus how it all gets played out in the measurement. I had some big picture questions, and maybe our country has just become more pragmatic and practical. Maybe we're following NIH funds. Maybe I'm not sure, but it just seems to me, have we given up on the idea? I mean, as academics on comprehensive healthcare in terms of like other countries, because I'm hearing less and less of that and more the pragmatic of how do you get the county or
that train left the station, and the notion of a national health plan or health insurance coverage has bit the dust by and large. There are still people in our country who are fighting furiously for the concept, and in fact, in the state of New Mexico, for example, there's a bill that would basically trip efforts to create one of the elements in the Affordable Care Act, which are called health insurance exchanges, that every state was asked to create. If not by 2014, the federal government would create them. This particular group is asking not a bad question, which is, can we do a cost study first to see what it would cost to set up a health exchange versus a statewide health plan versus the model that the legislature originally was pursuing, which was wide open, sort of free market insurance opportunities without any controls. And really, from a strategic point of view, that group's effort is to try to just derail the implementation efforts in order to have the only fallback being a statewide health plan.
Well, how many states have similar moves now? Like more than 20, I know that.
Well, no, that's different. There's 26 states that have joined a lawsuit to try to prevent the implementation of one provision of the Health Accountability Act, which really is about individual mandates to purchase health insurance coverage. And the argument or the challenge is that the federal government can't force people to be engaged in the economic marketplace. They can't make us buy something. And yet, in many ways, people are already told that you have to buy car insurance in order to drive. The difference there is it's not the federal government. It's the state government that tells you have to buy car insurance.
But
So
we
it's
have
a-
to take care of them when they don't have health insurance and
state.
come to emergency.
It becomes a states' rights question. So it's going to be a very interesting court case. But anyway, that's constitutionally what the argument is about, and about 26 states were involved.